Thank you very much, everyone, for joining us as we discuss the role of hopefulness among health workers and the community members they serve in achieving sustained improvements in health outcomes. My name is Dr. Wendy Leonard, and I am the founder and executive director of TIP Global Health. I'd like to introduce my esteemed colleagues, Angele Bienvenue Ishimwe, who is the Director of Behavior Change for TIP Global Health, and she is joining us from Rwanda. And Dr. Ijeoma Nnodim Opara, who is the Assistant Professor at Wayne State University School of Medicine in the Department of Medicine and Pediatrics, and she's joining us from Detroit, Michigan. The cornerstone of primary healthcare delivery is the relationship between a frontline health worker and the community member that she serves. Primary healthcare is all about prevention, early diagnosis, early treatment, and continuity of care. To be successful, a community member needs to access care, she needs to receive quality care, she needs to adopt care recommendations at home, sustain those care recommendations, and return back for more care. Prenatal care is really a microcosm of this cycle, in which we have a very finite amount of time to build relationships and ensure that this cycle is successful. At Global Health, we believe that the driver of this cycle is strong relationships, and these relationships are at their best when both the community members and the frontline health workers that serve them are valued, capable, and hopeful in the future. And healthcare delivery systems must be designed to facilitate this relationship. In 2013, TIP Global Health began working with 9 rural health centers in Rwanda to create a continuous quality improvement initiative. We came together to set health outcome goals, and those were to decrease HIV transmission from mother to child and to improve child nutrition status for HIV-exposed infants, while also improving the system of care for all pregnant women and children under 2 in these communities. Together, once we set the health outcomes goal, we defined what quality care would be. And we identified 5 pillars of quality: clinical skills, mother-centeredness, health education, data management, and logistics. We created an objective observational checklist and then measured quality in all 9 centers. We aggregated that score and found that our baseline quality score was 39%. While this may seem low, we looked through the data to understand where were they scoring high. And actually, in terms of mother-centeredness, they were scoring really high. So we began by celebrating those successes, and then we looked at the areas where they were struggling and identified very simple projects that we could help implement to gradually improve their systems of care. And as you can see, the quality improved from 39% to 73%. But in 2015, funding cuts hit the health centers, and not only was staffing cut, but morale was deeply bruised. And that led to decreases in quality of care. So at that point, we introduced the concept of diffusion of new ideas, which is a perspective on how we move innovative thinking through a population and change through a population. And then we also instituted individual health center improvement cycles. So rather than all 9 health centers choosing one project to work on, each health center would go back to their colleagues and to the mothers who they were serving, identify improvement projects to work on, and then come back and share the outcomes with the group each quarter. And you can see from that point on, we saw dramatic improvements in quality of care. And since 2008, we have had consistently above 90 to 95% quality at all times. When we conducted the diffusion of new ideas training, we also had people self-identify where they felt they fell along the innovation framework. And you can see that the vast majority of nurses and midwives we've worked with identified as early majority. So not innovators or visionaries, but they're willing to try something new if it's already been tested. So during this period of time, we measured our health outcomes, and health outcomes were dramatically improved. We virtually eliminated mother-to-child HIV transmission. We have had no cases in several years now, and saw dramatic improvements in childhood malnutrition rates. And we repeated this exercise of diffusion of new ideas in 2018 and found that these nurses no longer were waiting for others to test out new ideas. They were actually the innovators themselves, starting to think through how can they continue to improve systems in care and drive change. This really helped us to think through what was the undercurrent of the success of this initiative. And we really felt that through identifying short initiatives where they could see success that was leading to an improvement and achievement of their long-term goal, we were really driving a sense of hopefulness. What is hope? Hope is generally the desire for and belief in a positive future. And we are now undergoing rigorous research to confirm the influence of hopefulness on health outcomes. We utilize an objective tool called the Herth Hope Index to measure hopefulness. It can be broken down into 3 subsets: interconnectedness, future-oriented mindset, and readiness for change. And the Herth Hope Index measures both overall hope and also these subfactors. When you think about this, the quality improvement initiative we implemented, we really focused on interconnectedness by bringing nurses together from different health centers, having health centers working with mothers that they were serving to build interconnectedness. We identified ways to foster a future-oriented mindset by celebrating short-term wins that were getting people closer to the long-term goals. And we decreased the barriers to change, making it easier to change, adopt new ideas, and that was promoting readiness for change. So I would like to now introduce you to my colleague, Angele Bienvenue Ishimwe, to share her incredible work that she's doing on the research initiative related to hopefulness.
Thank you, Dr. Leonard. In Rwanda, we are conducting a sequence of researches to see or to investigate the factors that are related to hopefulness, factors that are mitigating hopefulness or decreasing the hopefulness. But to do so, we first started with establishing a tool that could allow us to measure the hopefulness. So that tool was initially designed in the US, as Dr. Leonard said. It was the Heart Hope Index that we adapted and validated in our culture. A second research that we are currently conducting is to understand the influences of hope to healthcare workers and then to mothers that they serve. After that, we identify interventions that we will design or co-design with the healthcare workers so that we can also implement them in their community or in their health centers. After that, while we will be implementing, we'll also do the evaluation to see if the intervention that we are implementing are having an impact on the health outcome, first on the hopefulness, but also on the health outcome for both healthcare workers and for the mothers that they serve. Next. This is the first question of the Heart Hope Index. This first question is the initial question before we translate it in our local language, the Kinyarwanda. Initially, it is saying I have a positive outlook toward life. So what we did is to first put ourselves in the shoes of our stakeholders here, nurses, midwives, and pregnant women, and see what are the common way that we are using to respond to questions. We found out that self-administered surveys are not common in our culture, so we adopted the second option, where a person will be asking a sort of survey or interview. Next, the direct translation didn't work. It was not really good, but when we translated it into the second translation, that is when we found that it will work by asking our stakeholders, mothers, and healthcare workers about the comprehensibility of the question, if they can be able to respond to the question easily, if they can truly give a response. So we did that through our focus groups. And then from the first question, which was, I have a positive outlook toward life, it's changed to, do you believe that your life will be better in the future? So this is the question that that was adapted after running through the adaptation process. Also, we did it for the response option. Thank you. The response option, which was initially strongly agree or strongly disagree, that scale was not really working in our culture. So we gave through the focus group, we shared the different types of scale. We shared the scale from 0 to 1, scales from individuals carrying the burden on their back, and this the scale of cups filled with water. And this one was very loved by our stakeholders, the mothers and the healthcare workers, and they've chosen these cups. And when we be giving the survey or interview, we read the question, then they will answer yes or no. Then we will ask them to compare your belief or your feelings with the cup illustration to indicate which cup best fits your answer. And then they will choose among these cups from 1 to 4. When we did this, we were sure that we have a questionnaire with 12 questions that are really good for our culture. But the other question that we have is really these 12 questions have the same properties as an initial index. The index, the Herth index with 12 questions, measured the interconnectedness, the readiness for change, and then future mindset. So we wanted our also to be able to measure those the 3 factors, keep the properties as the initial index. So we ran a survey with over 200 healthcare workers and healthcare recipients and see the properties of evaluate the properties of our questionnaire. So it turns out that our tool, those 12 questions, from the response that were given, our tool have the same properties as the initial one. Those 3 structures, we confirmed that in our tool. And also there was internal consistency of the responses that were given and the reliability of responses within time. So that was really a release for us, because not only we had a tool to measure hopefulness, but it was the first tool established in our country, even in East Africa. Next. So that was the first research that we did, and we published it. Now, currently, we are conducting another research, a qualitative research, as a landscape analysis to understand the influences of hopefulness among healthcare workers and among healthcare recipients. We conducted focus groups and interviews for over 50 focus groups and interviews with healthcare workers, and then we went to key individuals, policymakers, and researchers to make sure that we are gathering all information. For healthcare workers, what we are really reading from the transcript that we gathered is that their hopefulness is really influenced or decreased by the environment they are working in, the leadership they are working, like the leadership they receive, the communication that is used for them, and also the impact that they are making in the community and the way they are treated by their community, because most of healthcare workers are passionate. They entered in healthcare system because it's their passion. So the impact they are making in the community have a huge influence on their hopefulness. For the part of mothers, pregnant mothers or breastfeeding mothers, their hopefulness, what we are reading, is really influenced by the relationship that they have with their healthcare workers. If I can say, the ability of healthcare workers to create the relationship, a strong relationship with them, so that they can feel confident, trust between them and their healthcare workers. Also, the way the information is communicated to them, and also the way the technological tools are being used, because this is new. Sometimes it is being used well and it is increasing the interaction, or it is not being used well and it decreases the interaction, and the workflow, everything is destroyed because of the way technologies is being used. Also, the previous experience that a healthcare recipient, have within health systems influence their hope or the trust that they have in the health systems, but mostly the trust they have to healthcare workers, because they are the front line. They are the one that they see every time. So this work was not only being done here, but it was also has been also appreciated elsewhere. Next. So when Henry Ford Health Systems traveled to Rwanda with Robert Hood Health Foundation, they came to Ruri, and they were impressed by this Hope initiative. So they invited us in Michigan, Detroit, to share our experience and to learn from them. We conducted a 3-day workshop where we shared experience and see ways to design solutions to inspire hopefulness. I would like to introduce Dr. Opara, who have been in Rwanda and who were in that workshop to share her insight. Thank you.
Thank you, Angele, for an outstanding presentation, and thank you also, Dr. Wendy. My name again is Dr. Ijeoma Opara, and it's my pleasure to be here on this day to share this conversation around hopefulness and how it can translate to healthier communities, healthier families, healthier moms and babies, and certainly a healthier society. And so, as Angele described, truly in the Detroit community, we were very impressed by the work that they were doing in Ruri, Rwanda. And we felt that it would be a useful and a critical, frankly, tool to explore here to address some of the challenges that we are experiencing. To speak more about those challenges, I think it's important to provide some context. As we know, the data for maternal mortality in the United States does not look good when it comes to maternal mortality In the US, among OECD and industrialized high-income countries, we rank one of the lowest at 17.4 per 100,000 births. This data we know is driven by ever-widening racial health disparities, where Black women's pregnancy-related mortality is 3.2 times that of white women, regardless of socioeconomic status or medical history. In the city of Detroit, the statistics plays out as you can see. On the left box, you can see that for us in the city, our maternal mortality is about 77.5 per 100,000 pregnancies. And on the right, larger box, you can see as it relates to maternal child health outcomes in our city, amongst the our Black populations, preterm delivery is about 14.9%, low birth weight 14.8%, infant mortality 13.9%, and severe maternal morbidity 3.7%. The reasons for these disparities is plain and simple: structural, systemic, and institutionalized racism, as it shows up in all aspects of society, including medicine and healthcare, as well as the resultant intergenerational trauma and chronic toxic stress that affects Black folks, and particularly those descendant of enslaved Africans in this country. From the stories of Anaka Westcott, one of the enslaved African women on whose bodies the field of gynecology was developed, as the story of Dr. Marian Sims, who is referred to as the father of gynecology, demonstrates, to contemporary experiences such as that of tennis superstar Serena Williams, who wasn't listened to even after she self-diagnosed her own postpartum pulmonary embolism and almost lost her life had she not vigorously advocated for herself. Structural, institutional, and interpersonal racism shows up in the historical and contemporary injustices related to Black women's reproductive health and birthing experiences. This is true inside and outside of the healthcare systems and on multiple vertical levels, including the provider-patient level. So the provider-patient relationship certainly shows a lot of potential for intervention to begin to address this issue. We know that the provider-patient relationship has been shown to impact health outcomes, and as I said before, presents an opportunity for innovative interventions that build hopefulness by impacting interconnectedness, which is one of the key components of hopefulness. In addition to readiness for change and future-oriented mindset, this becomes very critical. In building providers and patients who feel valued, capable, and interconnected, our hope here in the city of Detroit is to hopefully, pun intended, translate the same to our healthcare systems, where it becomes more hopeful. Next, the city of Detroit currently is undergoing lots of transition. We are truly the comeback city, and we do pride ourselves on being hopeful. And so in our first workshop, which Angele already described, it was really a fantastic experience with all manner of stakeholders in the room. And a question was thrown out: what does a thriving Detroit look like to you? You can see on the right the word cloud that was generated, and words that came up include equitable, inclusive, community, celebration, and at the bottom there you can see hopeful. We know that a thriving Detroit is a Detroit that is hopeful, and we do pride ourselves on being incredibly hopeful regardless of challenges and obstacles, and that we have overcome in the past, and we continue to overcome as we move forward. And we apply the same to certainly as it relates to maternal and child health. And we're hopeful that we will indeed disrupt these disparities and bring about equitable, just health outcomes as it relates to the health of our mothers, babies, and our families, and therefore communities as a whole. With that, I pass it on to Wendy for our discussion.
Thank you so very much, Dr. Opara and Angele, for your beautiful presentations and really clear, direct articulation of the challenges and the potential that we all have within healthcare systems. Dr. Opara, I was wondering if you could share, you've talked about where Detroit is today, as well as a vision of a thriving future for Detroit. Where do you see the role of hopefulness, and in terms of health systems in particular, what do you see that health systems need to change to facilitate hopefulness among pregnant women, particularly Black women in Detroit?
Thanks for that question. That's a really powerful question. I think that when I think of hopefulness and all the aspects of it, future orientedness, readiness for change, and interconnectedness, what it reminds me of is our factors, again, in the city of Detroit, we're 78 we're over 78.3, 78.6. You may see different data, even up to 80% Black or of African descent. And one of the commonalities in most Black cultures are certain qualities or characteristics that are encapsulated in those aspects of hopefulness. I think a lot of Black cultures really pride themselves on being hopeful. That is central to our experiences and the things that we're proud of. That's part of the internal and community resources and social and cultural capital, I think, that has lent itself to building resilience within the community, despite challenges that have been experienced over centuries in this country. And certainly, I think that the same can be said all over the world. So my practice, I usually practice asset-based practice, and my research design is really built around highlighting assets. I am very intentional about rejecting a deficit-based approach, really, to my practice, to research, to advocacy, and education. And so hopefulness, therefore, as an asset, because it, even in the ways that we're studying it, even as a scientific idea, we see it as an asset. It's being linked to positive outcomes in chronic illnesses. We have the data to show this is a very powerful thing. It's being linked, and now we're linking it to positive outcomes in maternal and child health. This is an asset. And so the way that I conceptualize it is that as an asset, therefore, it is critical to the conversations we have around improving and addressing health in Black communities and in families in as a whole, and specifically in maternal and child health. And I'll end on this. What does the health community and healthcare community need to change? It needs to reject a deficit-based approach to approaching pregnant women and children and families, etc. It needs to adopt and begin to reorient itself around the assets and strengths and resources of these families, of these women, of their, and of course, and their children and their other resources. And so by adopting a hopefulness approach and a hopefulness model to their processes, policies, practices, to their, to their care approach, their evaluation and management as it relates to, pregnant women and their families, I think that creates a stronger health system that can be in a how will I say, in a more empowered position to actually be of service to these women and their families and produce positive outcomes. That's what's missing for me, and that's true actually in many parts of medicine, is to really begin to disabuse ourselves of a deficit approach to these things and adopt an asset-based approach that really highlights the strengths and resources of communities and of patients and of course their families, and incorporate that approach into our systems in the ways we practice and even engage with them. So long-winded way to answer, but I think it's a very critical question, and we have to be very intentional about how we do that in a very real way, in partnership with our mothers and families that we're taking care of.
That is so critical. And one thing that comes to mind as well is we talk a lot about burnout among frontline health workers, whether we're in the United States or in Rwanda. And there's a lot of evidence that that relationship actually can increase hopefulness among a frontline health worker and decrease burnout. And so when I hear you speak, I think about how much we as frontline health workers can learn from the communities that we're serving, and how actually if we open the door to learning, as you were talking about community-based resilience and hopefulness, intrinsic hopefulness, there's so much that a frontline health worker can actually gain from letting the community members in to help improve the systems of care. So thank you.
100%. I think you're so right. And the pandemic has revealed that, right? There is a lot to be said where we have a lot of opportunity to build more resilient systems, and the healthcare system and the public health system to become more resilient. And I think key to resilience is hopefulness. And I think, designing systems and designing processes of engagement with patients and communities that are built upon a cultural and professional humility model, so that we are going in like, what am I here to learn from, right? Them. How can I learn from them? Not just on a one-to-one, which is important, but also how do we build our systems, in reference and reverence of the folks we're serving, right? From an asset-based standpoint, that there is so much we can truly learn to make our systems better that will serve us, right? By in terms of our wellness, in good stead, and therefore create a healthcare workforce that is fit for service, so to speak, right? Yes, you're absolutely right. There is so much we can learn from communities who have proven through the test of time, of all people of African descent all over the world, throughout the diaspora, and certainly here in the United States, have proven that we are experts when it comes to resilience. Having survived over 400 years of systemic and structural oppression, and despite multiple outcomes that we're contending with, still here. The very existence of us itself is testament to incredible, undeniable resilience. And that truly, if society were to reorganize themselves around the capital that our communities contain, we will be unstoppable. And that's part of, and I'll end on this note, that's part of the tragedy of systemic and structural racism. That's part of the tragedy of white supremacy, right? Is the part, and Dr. Kamara Jones of the American Public Health Association, and so many things, she's glorious. And many of the folks I really also want to lift up, so I never forget, really lift up all the people that do work in birthing justice, reproductive health justice, people like Dr. Joya Kriya Perry, and many other folks, and people like the Black Mamas Alliance group, and so many of the folks that are doing amazing, outstanding work in reproductive health justice. I just want to shout them out. But a lot of these scholars and activists and professionals and practitioners, have been saying the same thing over and over again. And Dr. Kamara Jones's definition of structural racism is a system that structures opportunity and assigns value based on the social interpretation of phenotype that does three things. It systemically advantages certain individuals and communities while disadvantaging other individuals and communities, and does a third thing: it wastes resources, right? It saps the strength of society. It essentially. And so it's the tragedy and the loss from a system that systemically excludes a group of people, and therefore it robs itself of its potential to be better, because it systemically excludes a group of folks that are truly a treasure trove of resources and ability to like really like move the bucket. So by creating systems where we are not listening and learning from incredible assets that we have, due to structural and institutional and interpersonal systems of oppression that we have refused to dismantle and eliminate and abolish, we constantly operate under our potential, right? And that's why the US is ranked last or one of last in terms of her peers in the world when it comes to health outcomes, period, and specifically for maternal and infant health, because of this inability to really connect the dots between systemic or systems of like structural systems of oppression built on white supremacy and its inability to actually achieve its own potential when it comes to health outcomes. So yes, Dr. Wendy, I agree with your assertion.
Thank you for that, Dr. Opara. And one thing that comes to mind, Angele, and we can talk, I'd love to ask you some more questions around your research findings. But to follow up on what Dr. Opara has mentioned as well, what really comes to mind is the power of the work that we've been doing in Ruli, that you've been doing with the team in Ruli, Rwanda, and how engaging mothers in the systems of quality improvement actually drove the dramatic increases in improvement. And we found that women that were coming as HIV positive women in the community were coming with a sense of stigma and isolation, but through this group became community leaders. And we found women like Philomena who would stand up and in front of hundreds of her community members talking about throwing away shame of HIV status and taking care of children. And I wonder if you have any thoughts on your experience having seen the engagement of mothers and the power of
Yes, the engagement of mothers in the health system or in the care that they are receiving really build something huge. First, the value that they are being given by their healthcare workers. Not only the healthcare workers are learning from them, but also they also trust the healthcare system. When they used to come to the health center to seek for the care, and they sit for, let me say, 1 minute with a healthcare workers just for that time to prescribe the medication, the monthly medication, and they just share the problem. Why didn't take your medication last time? Well, and the nurse doesn't have the time to brainstorm the challenges. But when they sit together in a group, they brainstorm their challenges by themselves. Again, in our culture, we have been driven by relationship, being together, by listening to each other, learn from each other, support each other. And that is the culture that a healthcare recipient or a mother is expecting to see when they go to the health center. But most of the time, they don't see that culture because a nurse doesn't have time to concentrate on one person. But when they came together, they have time to brainstorm their challenges, they brainstorm what is happening in their house, share their experience, and then start to see how they can start to do some small innovations that they can do in their household. And that also inspired the healthcare worker. The healthcare worker who used to not have time now can have time because they can see that mothers can started to create solutions by themselves. So the healthcare worker who is motivated, because most of them, all of them actually, they entered in the health systems because they are passionate about the the work that is being done there. Their first motivation is to see the impact in the community. because also they live in that community. If they helped a mother to have a healthy child, to have an HIV-free child, it's also their legacy. So they need, that's the first thing that is preventing them to have the burnout, which also make them to create or make sure that the relationship they have between them and their mothers is strong. So as you are saying, as Dr. Opara is saying, if the system is designed to foster that relationship and allow the nurses to learn from their healthcare recipient and use that knowledge to create more innovation to foster or to be to make also something good for themselves or for their health center, it will decrease their burnout, but also it will increase their hopefulness. Thank you.
Thank you so much. And hopefully health outcomes and thriving communities, which is what we're all striving for. So I am so honored to be in this group talking with you both. You're so inspiring. And even as it feels as though we have a lot of work to do, I personally feel hopeful. And also recognizing that hope isn't easy. This takes a very specific strategic focus and commitment to inspiring hopefulness in systems. And so thank you for maintaining that hopefulness even during the current situation where we are facing a lot of challenges, more than ever with COVID, but we still have to focus on hope in the future and making these systemic changes, eliminating systemic oppression, building from communities, learning from one another, and inspiring hope and learning from one another. So I thank you so very much. I'm going to just end by sharing our last slide, which is our contact information. And because time is short suddenly, I'm going to end here. But thank you again, both of you, and invite those to ask questions in the live question and answer. Thank you very much. Thank you so very much for joining us from Detroit, Michigan and Ruli, Rwanda. We welcome you to ask any questions and contact us at the with the emails listed here. Thank you very much.